Good afternoon. We're going to begin this workshop on craving. My name is Marc from the University of Bordeaux, and this workshop has been prepared by a team from the University of Bordeaux which is working on this subject. We're going to discuss with you a mixture of clinical and research data based on the subject of addiction and the place of craving, and anticipating medicine of tomorrow and digitization, which can also be used for clinical purposes. We have an incredible opportunity. We're very privileged in compared to other workshops, because this afternoon you're being protected from the harmful sunshine outside, and that would prevent you from working. So thank you to the organizers for putting us in this protected room without sunlight and temptation. We have designed this workshop to be as interactive as possible. So there are going to be moments when we speak and other moments when you're going to talk. And of course, we will respect the timing. We'll talk about craving. They'll be presented by talking about early markers for craving, because craving can be one of the early indicators of addiction. Emmanuel Baillet will also talk about this subject with us. And then we'll talk about how to measure it in daily life with Leah and Sarah. And then there'll be the question of biomarkers. A psychological marker accessible. A biomarker is more accessible, but it's always something that we are trying to find in the medical perspective. And finally, a question towards the end of the session: the new way of caring and accessing care for those concerned with a project presented by CUSEMA. So without further ado, let's begin. I'm going to start by defining what craving is. Craving is a wish to consume a substance, it's a pathological wish which persists over time, which is very intense and is uncontrolled. It's a central component of addiction, which will characterize the lack of control and which will be differentiated from suddenly quitting even after consumption. Craving can be seen as an individual characteristic. For example, when you consider craving as a part of diagnosis, or as something that fluctuates in an individual throughout the day, and we'll talk about this later. Amongst the 11 criteria diagnosed for troubles of use, we'll talk about peripheral ones, the consequences of addiction, for example, symptoms of quitting, certain activities in favor of usage, and central criteria, which will truly characterize this lack of control, and craving is one of these. We have carried out analyses, IRT, a theory of response to systems. It's a method in statistics to compare the behavior of criteria with each other, and with regard to the severity of the latent characteristic. So in this case, it's craving. So this is for people asking for requiring care for different tobacco, cannabis, alcohol, opiates, and cocaine. And in each of the graphs we've characterized, we've shown the risks. The red shows craving, and we can see that whatever the substance involved, it's one of the criteria which is the most prevalent. We can see this because in the curves, it's one of the most immediate trends. We can also see that it's one of it's the slope which will show whether it's something that can distinguish those who are ill and those who are not. And that can be observed for the 5 substances we studied. We also had the same type of analysis to see the behavior of this craving criterion with against others in other populations and other addictions. And we can see that craving stands out as something which is central, even in populations for where there's an addiction. We can also see that this criterion stands out for behavioral addictions, food, video games, or addiction to screens. What we can see from this analysis is that it's one of the most prevalent criteria, one of the most discriminating. We can even see it in subjects with a very low severity of addiction. And we can hypothesize this. It's one of the first criteria to appear in the development of an addiction. So we want to explore whether this is not a good criterion to diagnose or to predict addiction in certain subjects. Rather than waiting for questions until the end of the workshop, does anybody have any questions that they would like to ask now? In terms of the definition, the speaker hasn't got his microphone. Microphone, please. That's a good question. Any other questions? Who out of all of you have never heard of this word before? Who has already heard this word? Everybody. And a question. Microphone, please. The speaker doesn't have a microphone. We'll see this later on. Craving is defined as a will, a wish, an intense wish, which cannot be suppressed, to do something, to consume something, and these can lead to an addiction. And when we analyze cases, descriptions in literature, it's not just a very intense wish, but those who suffer this, there's a particular quality in craving, a quality in it's a wish, but it's different from a normal wish, which is usually due to the environment. If you're here, despite all the efforts by the organizers for you not to come into this dark room, you still come. And even though we've put a sign outside saying what it's about, you still come. You heard about craving? What's that got to do to TDH? Is this a compulsion? So you wanted to participate in this workshop and you found it. It's adapted to the environment. Craving is a very motivating wish, but the individual can see that it's not his or her choice. because when you're addicted, what we see is many subjects are unable to describe this wish to family, friends, and practitioners. We'll try to explain what are the questions to be asked to determine whether it's a craving or not. The difference between compulsion and craving, when it's triggered, it imposes itself on the individual and it feels like an impulsion as an idea or an action which is imposed despite their own will. Are there any other questions? Inversely, if perhaps you will lose interest in this workshop and you want to leave, it's carried by another will. So you can see what we presented in the data which describes a craving. We can see it's the most specific and the most prevalent. The question which we need to ask, even in the most severe cases, is it not the first? Is it not a marker, an early marker of addiction? This is one of the questions we asked, and before we answer this question, in terms of, from a research point of view, I'd like to talk about the application KANOPEE, which for COVID, the laboratory implemented a public application which is accessible on App Store and Google Store, and its aim is to help people in terms of their usage. In terms of, there are several studies which show clearly that because of COVID, people have changed their consumption of substances in a negative manner and have become addicted. So the aim of this application is to help people to self-assess and see what their situation is. It's a virtual assistant who interacts and asks questions and accompanies them. The application, it evaluates sleep, not just consumption, but also sleep patterns, which can be disturbed due to stress. And here I'm concentrating, however, on addiction. So it collects information, general information, socio-demographic information about the person, about the subject. If it's health, it's a patient. And during the confinement, if it's during confinement or not during confinement, then it evaluates the consumption. It describes the consumption of the person and tries to find, based on all this information, based on the screening, the risk of addiction. So you have alcohol, tobacco, and see people where the risk of addiction for cannabis as well, or screens, and see whether people have experienced craving. It asks different questions about the acceptability of I'm afraid we can't hear it. So the virtual assistant greets you and asks you, like a true clinician would, to provide you support. And the application asks whether you have a problem with alcohol. And asks whether you wanted to reduce your consumption of alcohol over the last 12 months. Have your family and friends made any comments about this? Have you got the impression, are you under the impression that you've been drinking too much? Do you feel you need to drink alcohol as soon as you get up in the morning? Tell me, on average, how many glasses of alcohol you drink per day. Talk about, please say the standard number of glasses as would be served in a bar. So the application asks a certain number of questions, the same with tobacco. And it will provide feedback to the person. It will give the results, like as if you'd had an interview with a real clinician. So after this screening, it will tell you, can identify whether there's a craving or not. So either the person is under a certain threshold, they're negative, and in that case, they're informed that the situation is correct. They're encouraged to remain careful. Or the other possibility, the person is positive and or has or doesn't have cravings, and in that case, they're given an agenda. In this agenda, what we see is that we ask the person to give themselves an objective in terms of use, so we test the ability of the person to self-control. The person determines every day an objective in terms of usage for consumption which is problematic, alcohol, tobacco, cannabis, screens, and every day they note they note down what they've done, and they're reminded if they forget to do so. So this happens over 7 days, and after 7 days, the application will provide feedback analysing whether the person has achieved their objectives or not, or whether they've gone beyond the objectives. And this can be obviously readjusted. If the person has done what they set out to do, then the risk is reduced, and the situation is therefore reassuring, and another evaluation is proposed in 1 month's time. However, and the person is reminded to remain careful. If the result is negative, that means that they've gone over the level of consumption that they set as an objective, and the application will either propose another evaluation in 7 days. In 7 days, if it's positive again, then they are proposed to do it in a month's time. If the person doesn't want to redo it in 7 days because they're not satisfied, they have the option. The application gives the option of contacting the doctor or a health professional, a psychologist, a nurse, a practitioner, etc. So if they've chosen the agenda option and in 7 days it's negative, they've not achieved their objectives, then the application will recommend seeing a professional. And for those who have achieved their objectives, then the situation is reassessed in a month's time to check whether the items which were seen as risk factors have disappeared or not. The advantage of this application is that it's new technologies applied to a tool that we've been using in the field of addiction for many, many years to identify people at risk, and it's enabled us to intervene before it's too late. The advantage of this application is that it can reach out to many, many people, and especially people who won't systematically consult a health professional. Many people that we meet often come once they're confronted with the secondary effects of addiction, and the situation is very serious. So this enables us to identify very early on people who, well, this wouldn't otherwise have been possible. It proposes and you can improve the situation. It's improve your diet, for example, and it can recommend consulting a professional. Anyone can download this from the Google or iOS store. You can offer it to patients, or perhaps some of your patients have actually said to you that they've used an application that's enabled them to identify an addiction. So don't be surprised if this happens. Or perhaps if the person has authorized the app, then it will send you an email directly. This can also be used to recruit people for research, because we've acquired anonymous data, but the telephone knows the person has such and such a characteristic. This would enable us to recruit people, offering them the possibility of taking part in research based on their characteristics. They could be they would be asked based on your profile and the feedback. And the person is given the possibility to say yes or no and accept or not taking part in the research team's work. Are there any comments or questions that anyone would like to make? So it's an RPIB tool for use during COVID and also to recruit people. I'm sorry, the speaker has not got a microphone again. Microphone, please. The question, have you ever felt craving over the last 30 days? There's a definition given of craving because many people don't know what it is. But in the consumption diary, every day they're asked to note down the amount of substances consumed every day, and the number of craving episodes and the intensity. And there's a question over there too. Microphone, please. I wanted to know how you created this and how there's and to what type of health professionals they are sent. This is an important question. What is asked? The person is asked to designate, to name the health professional, and by default, the person's GP is proposed. If the person says that they don't have a family doctor, then there's a list of structures that is provided, which is registered with the regional health authority in each region. We know that one of the limitations in terms of care for addiction is the value judgments made by certain professionals or by certain GPs. So I was wondering if putting people back into a classic circuit it's a very relevant comment, because perhaps we can talk about this later as well. When we ask people in this application, when we ask what they liked, what they didn't like about the application, many people say, for these delicate questions in terms of consumption. They're more comfortable with their telephones and with a virtual assistant than with a true human being, because they don't feel judged. And this is especially the case for the less educated and those in more precarious situations. So it enables us to reach out to this population where otherwise they wouldn't come until it's perhaps too late. And this can lead to a craving manager where it's given independent answers. On the previous slide, you showed cannabis, cocaine. I think that one of the limits, we have to be very careful of different pictograms we use to use a syringe about opiates. It's perhaps one of the prejudices. So here too, it's another very good comment. We're trying to collect this information, and what we've planned to use this feedback to find out how to improve things, and what would be illicit, what would be uncomfortable for them. To illustrate this craving, which is very impulsive and which encourages people to consume substances, olfactive. When a stabilized patient gets in the car and has to go to Geneva for Lausanne, they stop at a petrol station in Geneva, after Geneva, and as they fill up, the benzene smell evokes a terrible feeling of craving and encourages them to go and consume cocaine again. Another visual example, one of my colleagues was caring for a drug addict, and they're walking in the countryside, and during harvesting, all of a sudden the patients feel very uncomfortable, because they'd put the hay into plastic, and this reminded them of small bags of cocaine. I know it seems very far-fetched, but it illustrates some of the problems. It's an excellent description of the conditioned answers, and that reminds me, tomorrow, Thursday, there's a plenary session on this question of conditioned effects from animal to man. But these are very operational examples that you've just given. Microphone, please.
Tout à fait en lien avec la...
What about the triggers? You just mentioned the triggers in terms of craving.
Donc, oui. Donc, je passe maintenant à...
And now Emmanuel Baillet. Now, to summarize, this is just a digital tool. It's only a tool, but it allows to perhaps reach out people that wouldn't be part of other systems. So good afternoon. Earlier on, we asked questions about craving. Wouldn't craving be one of the first marker of addiction, one of the first symptoms? KANOPEE is an application that has allowed us to recruit patients for a survey on craving as a precursor to addiction. So what happens in concrete terms? As you saw, patients are assessed as part of the app, and those who meet the inclusion criteria with no usage disorders are invited to take part in the study. So we're left with two groups. One is for users without any SUD, and one group with cravings. one group with cravings and one without cravings, actually. Every 3 months, they're assessed with different tools. And in particular, we use DSM-5 SUD criteria. So we just check any possible change in the criteria over the survey, which lasts for a year. And this allows us to see if SUD becomes bigger among those with craving during at baseline, or those who didn't have any cravings. Cravings might be an early precursor of a substance use disorder. So we started the survey by the end of June 2021, and we now have 28 participants, and we wish to have a total of 200 participants. So if you have any questions about this survey, please feel free to raise your hands. Well, we'll continue therefore. My name is Laura Lambert. I'm now going to talk about craving not as a diagnostic aspect, but as something dynamic. As you know, craving may change in terms of intensity or frequency within the same person and within the one same day. You may have strong cravings or not so strong cravings for a short period of time or a longer period of time. This is triggered by both internal and external factors like emotions. For some, it will be negative emotions, others positive emotions that may induce, trigger cravings. It can also be stress, fatigue, etc. Coping strategies can sometimes help any individual to reduce those cravings, such as getting in touch with a close friend or relative, etc. There are also other factors that may trigger a craving. The people you talk to, what you're doing, if you see someone using substance, if you're being offered the substance, etc. This is the case in some people. In the same way, if the substance is available at one given time, it may trigger a craving, but for some other people, it's just the ban for that substance that triggers the craving. Some treatments will, of course, decrease the intensity of craving, but neuroleptics in some cases may increase the intensity of cravings in some patients. Now, what is important, and that was mentioned before, whether internal or external, once repeated, these factors will be, so to speak, conditioned to trigger craving, even if the substance is not available, or even if the conditions are not, I would say, positive for that. Some conditions, some situations trigger a craving. Now, to further dig into cravings, if you're clinicians or if you are a researcher, you know that we have scales. You just check cravings over the past few days or few weeks. What kind of cravings did you have? What was the intensity of your craving? Are you having a craving right now in this laboratory where no substance is available? So it's totally different as being in an environment where the substance is available. So it's different whether you are in a laboratory or talking to a patient. So we have something that we call the ecological momentary assessment. So you can use mobile systems like a smartphone to collect real-time data. So this allows you to have the information collected when it happens, and this can therefore be done in the subject's natural environment or spontaneous environment. So it's indeed the ecological environment of the subject that counts. That is the actual environment. What factors may have influenced that craving, etc. And this is something that can be checked repeatedly over time. In one same day, this can be measured several times, depending on the environment, etc. So on the one hand, we can check the variability of cravings. Why not in the morning, but only at 2 p.m. and even more at 6 p.m., etc. So with these repeated measurements, we can study the chronology of events. Which event appeared and may have triggered a craving? And in this case, we have the chronology, the sequence of events. And for that, we have set up a study which is called CUSEMA. So what is it all about? It's like the EMEA study. It's an observational study which is aimed at better understanding the addictive behavior of a subject in his or her daily environment, with the various emotions that may change the person's feelings. So this study is done over 2 weeks. So subjects have touch screen pad and therefore can answer questions 4 times a day. And for each assessment, the question rates will help us collect information in relation with the addiction. For example, we ask, have you been in touch with one or several cues that are related to your use? Did you feel a craving? What was the intensity of that craving? Have you been using substance? And if so, how much, etc. So for you to better understand, we're going to introduce to you a typical questionnaire. So for example, here, this is a demo, actually. This is the first question asked in the morning. So the app has been set in such a way that the app here has been set for cocaine addiction. So first of all, we also ask questions about risk reductions, and we also have what we call an insight evaluation, but my colleagues will tell you more on this just after me. So here we have a question. What are you doing right now? Who's with you? So this allows us to understand if this type of situation or this type of person may trigger a craving. We also know what the person was doing just before, how he or she feels, sad, happy, etc. So we collect information on stress, tiredness, and other factors that are associated to craving, as we mentioned before. They also ask questions about what they have had for food. Have they also had any treatment, prescribed treatment against addiction? What about the observance of their treatment, if any, etc. So in this way, we can check more information. We also check the symptoms of craving, what kind of events appeared during the craving phase, what kind of psychomotor events appeared. We also ask about their consumption. Is it easy to resist this need for consumption? Have you considered strategies to cope with craving? Have you been in touch with specific environment situations that are in line with or that are related to substance use? Have you seen, for example, a syringe, or have you seen an ashtray if you try to quit smoking, etc.? Or have you been visiting places that are related to substance consumption? So we also consider their consumptions, whether in terms of habits, places, situations, and we try to identify the risk factors associated with consumption. Were they angry? Were they sad? Were they talking to someone, etc.? As to risk reduction, we ask questions about sharing syringes, what kind of routes did they opt for, etc. The reasons why they have been using substances, was it because it was available, because they just wanted to do it, because they felt the need for it, so they had a craving for it, or for any other reason? We also ask questions about how much they've been using. Do they feel able not to use substance? In fact, these questionnaires last between 3 and 5 minutes. Morning questionnaires are slightly longer than evening ones, actually. And we also have questions about other types of substances. Of course, this app is focused on one specific substance, in this case cocaine, but they may also be using other types of substance. They may have therefore replaced I would say, the focus, the substance in focus by something else. And this is something that we want to know. Now we have questions about insight. What is the insight? It's the ability to acknowledge an addiction. How much do they feel they are being addicted? How much do they feel that a treatment is necessary for them to reduce their consumption, etc., etc. So I'll stop there. Stop there with the demo. Any questions? Thank you. So that's quite an exhaustive collection of data. But if you ask these kind of questions 4 times a day, don't you think that this is also a way of replacing the subject back into an environment where he or she might feel cravings again? It's a very good question indeed. And this is very often raised. In fact, we checked whether exposure to such questions would increase craving. Actually, it seems that craving is decreasing. Several studies are now, or surveys are now using the same methodology, and actually asking the questions on a regular basis seems to be helpful for those patients who are trying to quit or that have just initiated their addiction management. Well, that's highly interesting. Do you have certain types of persons accepting to follow your questions or your questionnaires, or do you have people that do not feel happy with this? Well, on average, patients are just starting. Well, this is the early phase of the patient's management. Some people just refuse any collection of data, whatever research or survey it is. They just reject the idea of answering questions. some, for example, tell us that this may be an issue at work. It may be detrimental to their work. But in most cases, people are pretty happy with the app, and only a handful of them cannot use it. I actually saw people with shaking hands using the tablet. In fact, it's very easy. Questions are easy to answer, and it becomes much easier as time goes. And some people like it, actually. Some would like to keep the tablet. We did the same kind of study a few years back, and we compared studies. We compared results between those who accepted to take part in the survey and those who didn't. And we didn't see any change or any difference in the severity of addiction. It seemed that it was pretty representative of the subjects included in the subjects included in the survey were pretty representative of the population, generally speaking. But again, it was in the early phase of the addiction management. Well, that's quite interesting for research purposes, but I think this could be quite helpful for clinical purposes as well. More questions? I just mentioned the fact that we used a pretty similar methodology a few years back. So in this survey, we evaluated conditions, stimuli, craving, and use, substance use. And we came up with the so-called cues, craving, usage. In fact, the number of conditioned stimuli in the patient's environment is associated to an increase in the craving in the following hours. And for that, we checked the so-called standard cues, that is those stimuli that are associated with the substance itself or its use, such as a bottle for alcohol or an ashtray for smokers, and individual cues, that is the cues that each individual would relate to his or her own use. So in the beginning, we just asked them what were those situations, people, objects, etc., that would trigger a craving. We tried to screen all types of cues to obtain the individual cues. They were fed into the tablet so as to be able to ask questions several times a day. And we evidenced the fact that with individual cues, we have a stronger predictive effect on craving. And this model also showed that craving is also predictive of a soon-to-come use of substance. So craving would be the central drive of substance use and therefore of relapse. In other words, the hypothesis is that craving could be a marker, and this model was evidenced for substance addictions. Now, the question is it true for behavioral addictions? This is something that we will now consider with a new app called CUSEMA, CUSEMA. In fact, if you take a look in the literature, there are indeed similarities between substance addiction and behavioral addiction, such as loss of control, fruitless attempts at quitting, and we also found neurobiological similarities. Actually, it seems that the same brain regions are stimulated for substance addictions as well as for behavioral addictions. If you focus on the literature, you can see that a certain number of papers show that this model can be seen with cues inducing cravings, and of course a relationship between craving and use. That is, craving should be a predictive factor for you, for the use. And this is something that was checked in laboratory conditions or retrospectively with such apps. So what about daily life now? This is something that we want to know. We want to do the same type of survey, but on a daily life basis with the CUSEMA model. Now we'll present to you another way of collecting data for research purposes with CUSEMA again. So, as we said, there's a relationship between craving and use. Having a craving is indicative of an increased use. But this is something that may happen in the short term only. We don't have data for long-term effects of cravings. Knowing that addiction is a chronic pathology, we need to know more about the long-term situation. So for this, we wanted to know more about craving in the early phases of patients' therapy. And I will now present to you our protocol. So during inclusion, patients requiring the management of their addiction had to answer different questionnaires. For example, the addiction severity index to assess, as the name goes, the severity of the addiction. And then another one with interviews to assess possible psychiatric disorders using DSM-5. Then the EMA protocol that was mentioned before was used with the variables in question, such as which substance, which craving, and what happened between day 1 and day 14. Then every 6 months we had another questionnaire, the one I presented to you before, so that we could have a good vision at 5 years, which is pretty long term indeed. And with this, we were able to set up 2 groups. A group of subjects that were still non-users after 5 years. They didn't use substances in the last 30 days of the early management, and people who'd been relapsing over the first 30 days. As you can tell from that graph, non-users appear in green at 5 years. I mean, are in green, and relapses are in red. We can see a decrease of craving over time. So during the first 2 weeks of the management. Besides, this decrease is slower for the relapsers at 5 years. So the behavior of craving at the early stages of the addiction management could be predictive of the outcome of patients in the long run. Any questions?
Sûr, j'ai bien compris entre mes compulsions à regarder mon téléphone. Ce que vous dites, c'est que plus on...
In other words, the faster the craving is extinguished, if I may say, the better the chances of defeating addiction. We observed that in the long-term non-users, the decrease of craving is much slower than in the other groups. So in other words, the trajectory of the craving or the evolution of the craving during the first 2 weeks of management is key to predict how the patient will behave in the long run. Is it this decrease of craving for the first 2 weeks, is it not just due to a better observance or compliance? Or is it not because people are being more motivated initially and therefore maybe non-users at 5 years? Did you consider those additional elements, not just cravings, I would say the profile of craving or the I would say the interest of the app. Well, we don't really have this kind of data. We have data on about age, gender, etc. But it's a good question indeed. Well, that's part of the various working hypotheses. We just observed that the decrease of craving initially is related to a better outcome at 5 years. But of course, we may have several hypotheses. What can be the explanation to this? Because there are many things happening in just 5 years. We know that craving is also associated to a lot of other factors. Compliance to treatment, whatever treatment, etc. So these are areas to dig into, and we only have 39 patients. So we continue calling the lost from study patients to try and further explore the results. One of the potential explanations is that the follow-up of the cravings initially would enable practitioners to focus their attention on some people because they may be more sensitive than others or more difficult to deal with than others. So individual medicine, therefore, is quite interesting for those who listen to this morning's presentation. It's better to focus on patients to see who is more in need of attention and who is not, so as to have a more centered, patient-centered type of medicine.
I wanted to ask about what is the link between craving and the memory in terms of the reward system. Once you have the memory of it, then the more this is the case, the higher the craving. What is the link between memory and craving? I think it's a very good introduction to the next part because Laura Lombard is going to look at craving and insight. And this is linked to memory and the ability to be aware of one's symptoms. So this is, we'll look at this in a minute, not immediately, but we'll be going to look at this a bit later. So how can we use this application for clinical purposes? Because I said before, most of the time when you evaluate your patients, you're looking at retrospectively what happened last week, what happened. That depends on many things. Because to remember an event, you have to take into account the context, the emotion, was it relevant, and many, many other factors which, in addition to this, will mean that people will remember or not certain events. So this application is going to limit the loss of memory. With all the, it enables you to have graphics on request of the patient's request with the acceptance of the doctor, the following doctor, the intensity of the craving over time. When it's hit 1, there's no craving. 1, no craving. So most of the time there's no craving, but in the evening she always has a craving. And if you look here, I can see every time there's no use, there's no UV, there's no substance used, there's no craving. And when there was one used, it was craving. So it's more in the evening and almost systematically. And almost every time she used the substance. So, for example, should we take into account environmental factors, like, for example, it's relatively also perhaps for the clinician, this is important information to predict when it's going to be the highest intensity of craving. We also collect emotions. So for this person, we can see that she had a very sad, a very angry, less joy, and the clinician can come back over and see what happened then. Was this event, did it encourage you to consume more, and see how we could avoid this type of use more. The same at the end of the study, in an increase in anxiety and sadness and anger and less joy. And so we can, with the clinician, the patient can see how to manage this. This enables the clinician to identify the keys, because there can be a very big difference between identified risk factors and real risk factors. This patient told me that when it was forbidden for him to smoke, he wanted to smoke. It gave him a craving. And another question, as we can see, this ban on smoking in his environment. And so when it's in bold, there's a ban on smoking. You can see there's in fact, in reality, there were times when it was banned, but when he didn't have a craving. And this is good information. So the fact that there was a ban on smoking in certain places was not a predictor. Anxiety is also a risk factor. We can see there's moments when there's no anxiety, but a lot of craving. But for this individual, so there are clues which are even more predictive. For example, a friend. When he was in the presence of a friend who, every time he was with this person, he had more cravings. This type of information is interesting for the doctor to see the context of the person is the best predictor of, is by far the best predictor. And for this person, identifying risk factors is not actually that easy a task. So this leads us to the notion of insight, because insight is the ability of an individual to recognize that he or she is sick. It's a multidimensional aspect. And we're interested in clinical insight. This is the ability for patients to recognize their symptoms, the consequences, and the requirement for care. The problem with addiction is that most people are not aware or not very aware of this. When there's an alteration of the clinical insight, very often they negate or underestimate the need for care. So they don't initiate care. Or when they are cared for, they don't think it's that serious, so they'll be less compliant. This was linked to less abstinence and a less good analysis in the long term. These people had a less good prognostic because they had they didn't have as good an insight initially. Craving is something which is associated to usage and to having to use this again. These people who tend to underestimate their symptoms and who are less compliant, would there not be a link with craving? Because it's subjective, they're able to express their craving, because of course they've got to and to be able to remember incidents of craving. So to answer these questions, we carried out several studies. The first was an individual study. We looked between individuals who had more or less insight. Did they describe differently their craving? And what we were able to show that during these studies, those had a less good insight. They had expressed less cravings. Is it that they have less cravings, or is it that just simply that they are expressing less their cravings? They're less able to talk about it. So we looked the CUSEMA application. The people who had less clinical insight had as many cravings when they're asked momentarily by the application, but when they're asked retrospectively, they say that they have less. So, so they are less severe. This leads us to think that insight modifies so we could use, for example, the certain applications which enable us to collect momentarily cravings to better identify and assess them. We also carried out a study, an intra-individual study. So within the individual, because the insight can also fluctuate over time, we looked at whether a particular time we had a reduction of clinical insight, and does this predict craving trends differently. And for the preliminary studies we carried out, it appears that if at a particular time for certain people there's a reduction of clinical insight, in terms of my, I think that I'm less ill, and in the next evaluation I will put less cravings. So potentially, our hypothesis is this clinical insight can modify perception and the ability to express your craving. So it'd be interesting to assess more systematically, because perhaps your patients say they haven't got a craving or they haven't had a lot of cravings, but they have in fact had as many as the others. Do you have any questions? I'm rather surprised by the conclusion of your final slide. Is it not that they could be better and therefore have less cravings? We could think it's because they're better, but their sickness is always there. It's their perception of the sickness which changes because they think they're better. And why do you think that? Because the level of severity is a global illness. So you don't think there are fluctuations? Potentially, yes. They feel healed, and as soon as they stop consuming and something positive happens, people say they're no longer ill. But you don't think it's because they have less cravings. We tested with the inverse case. If there's an increase in cravings, that predicts an increase of insight in the following hours, because they will feel more severe. But likewise, by controlling the previous cravings, the reduction of insight predicts less cravings. Perhaps I could add something here. The daily questions, we try to ask them so that they don't only concern a particular moment in time. We try to make them general and not just concern the present moment. In these studies, do you have people who have cognitive problems? Because it's quite regular when people abuse alcohol and Not everybody's able to understand the questions, and perhaps for them the craving could be expressed as an emotion, a bodily effect. Yes, we carry out cognitive skills, but we don't have enough subjects to control the numbers. We have carried out memory tests and episodic semantic for global screening and tests which check the executive functions. It's not only because that they have less cognitive functions that they have more cravings. For the moment, there are only preliminary results because of this. The advantage of measuring things on the moment. It's difficult to remember what did you do this morning, what did you do yesterday. But if we ask you what have you just done now, of course, it's easier to answer that question. So we can see this insight can modify the perception and the ability to express cravings. And we also know that cravings are often an internal phenomenon, which are subjective. And so it will be interesting both for clinical purposes and for research to find biomarkers to show cravings. So this part is about the biomarkers. Firstly, a little bit of literature before we talked about cues for usage and craving. This is something that can be captured momentarily. It can be self-declared by users. There's a need both in terms of cognitive and awareness of symptoms. We know what are altered in usage disorders for cannabis and alcohol and tobacco. We know that these cues, in addition to cravings, can lead to physiological differences, both in the laboratory with modifications of the electrodermal, the amount of cortisol in saliva. But however, currently there is practically no study, daily study. But we know that cravings can happen outside these stimuli linked to consumption. So there's no objective data. There are certain portable systems, Empatica, which is a bracelet which has to be carried on the wrist and which will enable several physiological parameters to be registered: electrodermal, the temperature of the body, movement, body movement, the blood pulse, with the variability of cardiac response, and this also enables us to mark events. So here you have one how it works. It's connected to an application on a smartphone where in real time you can have different physiological parameters. This is for the user and also for searchers. You can here have a visualization of all the physiological parameters which are available in a Excel database to analyze them using artificial intelligence or machine learning. How can this be used as a research tool? It's actually being implemented in the laboratory. We've included only people who suffer from cravings, because that's what we're trying to identify biomarkers. The fast test, which is between day 1 and day 15, with the different parameters I've just presented, and the marking events, where we ask the user to mark event moments when they have cravings. We put this together with the mobile device, enabling cravings to be captured in the natural environment with its fluctuations 4 times a day. Thanks to these two systems, we're able to go and look at the physiological parameters which are linked to craving episodes described by users. And then secondly, we, in 12 months' time, whether there's a relapse or not, to see if the patterns of physiological variation which exist are linked to relapses. How could this tool be used in clinical environments? It could be used to provide alerts. According to these physiological differences, we could predict the user who is experiencing a craving. We could also alert the care team who could intervene because it's predictive of relapse and therefore reduce the risk of relapse. Do you have any questions? Now we're going to look about how to avoid and manage craving with smartphones with something called Craving Manager. It's an application which we've created in a laboratory as a complement to with this application has a MA and a LMI aspect. This application is going to be the UMA, the evaluation, which asks questions regularly about consumption and the factors which can induce this, so craving and usage. And the intervention or part, where the application will monitor cravings and act on this as soon as it appears with personalized tips. It will also anticipate this craving by asking regular questions about the context of the subject, if they're in a context which makes them want to consume. So this is active. It can also be passive via GPS, for example. And this enables us to reduce usage and the risk of relapse. So we tested this in a clinical study at the Scholperhans Hospital Centre with 2 parallel groups. The objective was to test this application on the reduction of consumption in subjects who are not yet cared for. And concretely, there will be 2 groups. One, which will be the control group, who will only have the limited version of the app, and the experimental group with the full version of the app, with the LMA and LMI. And they will then be followed up for 3 months, for 4 months in all, with other tools. And so this clinical test takes place in different centres, namely in Bordeaux, Limoges, Poitiers, Bayonne, Grenoble, and the island of Reunion. To show you how the application works, the Craving Manager starts by personalizing. It enables, it determines, it'll be the first screening phase thanks to adapting the mini diagnosis. It will identify if there is in users the use disorders, and it will determine the severity of these possible disorders, And when it's first used again, screening is continued with a phase where the user will have to enter information and details to enable the app to understand his or her consumer habits, and they will provide names of places, the names of people, objects, activities, moments in time, or emotions. The individual will have to also enter what is a protected environment. All this information will later on enable the app to offer the user adapted and personalized help according to the different situations encountered. As my colleague mentioned previously, the way it works is that it uses the EMA method. For each evaluation, the user will have to look at the hours spent with the information about behavior, if they have been exposed to any of the cues linked to usage, if they've had cravings, or if they've actually used the substances. But the specificity of the application lies in the fact that its help is in personalized strategies and strategies based on providing standard care as we can find in healthcare venues. All of these can lead to an intervention. This is the case when a questionnaire determines that there's a risk situation. So, for example, if the user says they've been in contact with one or several associated cues, this is the case when they've experienced a craving or they've used it. An alert can be triggered if the geolocation, if GPS detects that the user was close to a place which has been referenced as being associated to usage. And they can also be triggered on by users who feel distressed. Every week, the app will provide a summary of the previous week, and this will be when the users will be able to visualize the consumption over the week and the intensity of craving with the reasons for this and why they requested assistance. It enables the individual to visualize whether there has been any potential progress and also to set objectives. The application, according to the evolution of the week, there are also words of encouragement provided and objectives. So, for example, in this case, an example of a message of encouragement is going to highlight the day of the week when they consumed the least. And this enables them to fix and set an objective according to this.
So as we told you, this app was submitted to a randomized controlled trial. But clinically speaking, things might be a bit broader because we believe, and we wish that this app should be used by individuals in full autonomy to get direct benefit, if I may say. But we also wish this app to be offered to people who need it or with a severe addiction to be directly connected to a health professional. It could be an alternative. We believe it is important because only 10 to 25% of people with diagnosed addicted are being treated. This is what we call the treatment gap. And it's crucial to reach out these people with an addiction, but who have not been included in the current care system. We would like to offer an additional system to be able to follow patients in between 2 consultations and then therefore reinforce compliance and observance. This type of app is aimed at offering an immediate intervention, whatever the situation and the place. And the collected data will be useful for physicians, because they can follow up their patients between 2 consultations and be made aware of any degradation of the patient's condition to be able to intervene in case of relapse. Now, as for research, the data collected by this type of app will help us better understand addictions, and in particular, better understand the natural environment of the individuals in question, whatever the addiction and whatever the individual's profiles. They can be used as a complement to a treatment, and this will allow us to add more information to understand the diversity of patients, the mechanisms of action of these therapies, and we also believe that it is important to combine these apps on smartphones with physiological sensors as those presented by Emma. Such devices would certainly improve the accuracy of the app and identify situations at risk. We can therefore predict, we should be able to predict that the patient is at risk, and we should therefore be able to plan an immediate action. So as a conclusion, I believe that these data and mobile apps will certainly help us improve patient-centered medicine. So that was our last slide. Before we continue with questions and answers, I'd like to thank the laboratory staff who've participated in this presentation, actually, and who also includes participants in the study. Thank you very much.